Next talk is by Dr. Vikram Khanna sir. Topic is treatment of allergic rhinitis.
Good afternoon, everybody. With the kind permission of the chairpersons, I would like to begin the talk. Treatment of allergic rhinitis is what we all do in our OPDs. It doesn't require an allergy setup or a diagnostic test. On history alone, you can make a fairly reasonably sure diagnosis of allergic rhinitis. The remaining part the phenotyping and immunotherapy would depend on the skin prick test and the other test results. The ARIA has classified allergic rhinitis. Important to notice the one written in red is in untreated patients, because after oral or topical treatment, the symptom duration and the intensity would change. So be very careful in your history. The guidelines are there for all the phenotypes, wherein the treatment part, the avoid part, and the immunotherapy part all are highlighted. So these are the various treatment modalities. Avoidance of allergens is primary, but practically nobody does, or very few of your patients would do. Many of the clinicians actually don't advise avoidance because they know the compliance for avoid measures is hardly 1% also. Try to educate your patients so that they know what they are allergic to and the benefits of avoid measures and taking proper treatment in the correct way. Pharmacotherapy is the mainstay of treatment. Those who don't respond to pharmacotherapy or are allergic to certain allergens that cannot be avoided need immunotherapy. There is a big hue and cry about surgical procedures, but please understand no surgery can cure allergic rhinitis. It's an immune phenomena. The surgery that is done is primarily for the comorbidities like DNS or turbinate hypertrophy or enlarged turbinates and nasal polyps in certain cases. If there is intractable sneezing, that can be controlled by posterior nasal neurectomy for a time period of 3 to 6 months. So that is the real importance of surgical procedure. There is no surgical cure because in the guidelines there is no surgery mentioned anywhere. A few things to remember: allergic rhinitis is not a sign or symptom of anti-allergic deficiency. Patients need not be on oral or topical treatment for the rest of their lives. Treatment of the symptoms does not mean treatment of the disease. This is very important to note. Pharmacotherapy can alleviate the symptoms but cannot cure the disease. Only immunotherapy and avoid measures can cure it. Pharmacotherapy has its limitations. It must be complemented by avoid measures and immunotherapy. The options, most of us in the audience are aware, so I will not spend much time. This slide highlights the onset of action of various class of drugs that we use and their respective duration of action. The requirements of an ideal oral antihistamine will depend on 4 things, that is the pharmacological property, the pharmacodynamics, the efficacy, and the safety. This is the timeline of the major antihistamines, and you can see that it started right from 1937. We had chlorpheniramine, then we had in the late 1980s cetirizine, then in the 2000s we had desloratadine, levocetirizine, and now the latest, that is bilastine. So the antihistaminics are divided into 2 generations, the first generation and the second generation, the latest one being bilastine. ARIA recommends the second generation non-sedating because of the side effects of the first generation on their actions on the various receptors that are outlined in the slide. A few things about bilastine: it's an inverse agonist of the H1 receptor with high affinity, more than fexofenadine. The dose is 20 milligram for allergic rhinitis. The only problem or the hitch is that it requires to be taken on an empty stomach 1 hour before or 2 hours after food. Otherwise, a wonderful molecule, but this is the most important part of giving this medicine, which is often neglected by our patients. It can be used now above the age of 12. It also alleviates the symptoms of nasal congestion and also has an effect on the eye symptoms. There is no drug interaction or any dose reduction in renal or hepatic conditions. And most importantly, the combination with Montelukast is available for patients who have allergic rhinitis with asthma. This table compares the various second generation antihistamines, and Bilastine is the only one which ticks all the boxes right. In India, the FDC of Bilastine and Montelukast is approved for treatment in adults. In the US, fexofenadine has been approved by the FDA for use in pilots as a non-sedating antihistaminic. We also use oral steroids rarely, but in a short course. Either you can use methylprednisolone or deflazacort in the dose mentioned. Please understand, especially in case of nasal polyps or in gross hypertrophic turbinates, your spray will act only when the nose is open, and that is why you need sometimes a short course of oral steroids. The anti-leukotriene agents we know, only Montelukast is available in India. It can be used in adults and children, but in patients who have concomitant asthma or uncontrolled rhinitis, to be used for a short duration and always in a combination with an oral antihistaminic. The US FDA has issued a black box warning for the use of Montelukast because of the mental side effects in adults and children, especially suicidal tendencies. So use it for minimum possible period. Ideally 2 to 3 weeks should be more than enough. The sprays, we know the benefits of all. I will not elaborate due to the paucity of time. The sprays are available initially as fluticasone, then mometasone came, then fluticasone furoate. Now we have the combinations with azelastine, and the latest addition is fluticasone or mometasone with oxymetazoline. This is particularly benefited in patients who have had rhinitis medicamentosa. The catch being that use only one bottle and stop it. Let patients not use it continuously, otherwise there can be issues. The most important part of the nasal spray is teach your patients how to use it. Demonstrate it yourself. Dummy sprays are available. The position of the bottle, the position of the head, the direction of the nozzle, all have to be taught to the patient so that they can use it properly. Nowadays we have pamphlets and QR codes also available, and if possible try to make them use it in front of you once or twice so that you're sure that they'll be able to do it properly at home. Azelastine is a topical antihistaminic spray. It can be used above 6 years. It has a faster onset of action compared to the steroid sprays. The only limitation factor is the bitter aftertaste, but now sweeteners have been added and it is available both with mometasone and fluticasone combination. Omalizumabs are the biologicals used, but not to be used in allergic rhinitis, for asthma or with chronic rhinosinusitis when symptoms are not getting controlled or there is recurrence. That is the only time. The prerequisite is you should have a high blood eosinophil count and elevated FeNO values. It also has adverse effects. One slide. The DGCI has approved it for adults more than 18 years for the following indications. The stepwise algorithms are available, both the IACI and the ARIA. So thank you for your patient listening.
Thank you, sir.
Thank you, Dr. Khanna.